Welcome to Medicine Motherhood and Missions, the podcast where we dive deep into impactful and inspiring conversations with amazing professionals who've turned their challenges into stepping stones for success. I'm Johanna, your host, and each time we meet, we'll explore the stories and journeys of remarkable individuals who are PAs, doctors, professionals, mothers, and mission-driven changemakers, from the halls of the hospitals to the hearts of our homes, and into the communities we serve. Join us as we uncover the challenges, triumphs, and everything in between, and see life through each other's perspective. If you're seeking fulfillment in your career and life, I've got something special for you too. Download our free guide on how to be a fulfilled provider. It's packed with tips and insights to help you thrive while balancing the many hats you wear. And for all those parents out there dreaming big while raising little ones, check out Little Evie's Big Dreams children's book series, available now on Amazon. These heartwarming stories inspire kids to chase their own dreams, just like you're chasing yours. So grab your favorite cup of coffee or tea, settle in, and get ready for uplifting conversations that will leave you inspired and equipped to make a greater impact. Let's jump in. Hi guys, hi friends. I'm so excited because we have today on the podcast Dr. Krishna Vedala. He is a primary care physician, board certified in internal medicine and obesity medicine, currently working for Norman Regional Health System here in Oklahoma. He also holds an MPH and an MBA. He was also recently awarded the Fellowship of American College of Physicians and Fellowship of American College of Health Data Management. His interests include obesity medicine, provider communication, artificial intelligence in healthcare, and healthcare leadership and policy. So thank you so much, Krishna. I really appreciate you coming on the podcast, and I'm so excited for our conversation today.
No, thank you so much. And I can't thank you enough for inviting me here, and I'm really excited. And I'm looking forward to answering a lot of your questions, but also getting a chance to meet your audience and answering any questions or concerns that they may have. And I really hope people can get something out of this episode today.
Yeah, for sure. I think some of our topics will be really interesting to a lot of people. And let's start off with, tell us about your journey to medicine, a little bit about yourself.
Sure. So again, hello everyone. I'm Krishna Vedala. As she's already introduced me. I'm not going to repeat where I work and who I am. I'm a physician. I do mostly see everyone above the age of 18. I got into medicine because I wanted to make a positive impact upon the people around me and upon the community that I grew up in. And it really started with the Oklahoma City Memorial bombing that happened in 1995. I was about 7 or 8 years old at the time, I think, and I was glued to the TV that night. And yes, it was just a horrific event that's really played a big role in a lot of our lives. But to me, I also was seeing a lot of the healthcare providers that are taking care of those victims. And that's where I really started looking at healthcare and really falling in love with medicine. And then from there, it was a journey of finding positive role models, whether it be family friends or other just personal friends that I've known that have relationships with other providers. And then getting into medical school, that was the journey. I didn't get into medical school till my third attempt, so I really had to really fall in love with this to really want it that bad. And during the course of that journey, though, during the course of getting into medical school, I've had some wonderful experiences. I worked as a medical assistant with a cardiologist at Integris Baptist. Then I also worked in medical billing, and I also was a graduate research assistant at the Stevenson Cancer Center. So I got to see a lot of different facets of healthcare before going into medical school. And then, of course, got my MPH during that time too. And then medical school was obviously not fun, not easy. You learn a lot. It's a very stressful time. People that you meet in medical school, they're not the same by the time you guys graduate. So a lot of people change because of just the daily stresses. But at the end of the day, I wouldn't change a thing about my journey so far because it's really made me who I am. And I think the experiences that I accumulated during this journey is really what helps me now on a day-to-day basis. I feel that I was somewhat of a non-traditional medical student, and that was a good thing because I already kind of knew what I wanted to do. I already kind of knew the daily intricacies of this job. And so I was looking forward to really getting through medical school and residency and then just coming out. And today, I enjoy going to work, which is kind of weird. A lot of people are like, what? Why? But to me, as an outpatient primary care provider, that's what I'm here for. I'm here to build relationships with my patients. I'm here to communicate with them, and I'm here to address their needs. And that really drives me on a day-to-day basis. Um, of course, during the course, I've also met a beautiful person who I now call my wife, and we actually got married the week before residency. So that was a good. I think that was a very important phase, an important thing to do. But my wife, I always say my wife Namrata is my biggest accomplishment in my life. So that's also very important to find someone that who really understands what you're passionate about, but also understands that your job is not easy and that your job oftentimes does require some degree of sacrifice, not just with you guys, but also with them. And so I'm fortunate enough to find a spouse that really understands my passion, and of course, can't thank my mom and dad enough for helping me during this journey, and my other partner in crime, my brother Veer Vedala, who's actually a family medicine doctor, and we both do work in the same clinic in the same building. So there's two Dr. Vedalas down in South OKC.
That's amazing. Couple of things I wanted to pick out of that because, first of all, you talked about the Oklahoma City bombing and
Mm-hmm.
how that traumatic event in history kind of propelled you into your love of medicine. And
Mm-hmm.
it kind of like is an interesting point of history, meaning we just also had the first NBA championship win
Yes.
in
Yeah.
Oklahoma. I think
Yes.
30 years since that bombing. And so
Mm-hmm.
they were kind of carrying that kind of victory in showing
Yeah.
the renewal and resilience in the spirit of Oklahoma City, too, right? And
Yeah. I mean,
how, yeah.
it's a huge deal because I remember growing up in middle school and high school, downtown was not what it was today. For all you
Mm,
younglings, we're not that old, but downtown it's really different now. It's vibrant, right?
mm,
It's
yeah.
exciting. People want to go out to downtown, whether if you live in the suburbs or whether if you live even,
Mm,
50, 60 miles away. And it
yeah.
really speaks to the resiliency of, and you said it right, it really speaks to the
Mm,
resiliency of the city, the
mm,
tragedies that we've seen. And people forget the Oklahoma City Memorial bombing was actually the biggest domestic terrorism incident until 9/11, and it probably would still be
yeah.
the second biggest one, just because
Mm,
of just the horrific experiences that we've had and on that
yeah.
day. So for the
Mm,
Thunder to win at the 30th
yeah.
anniversary,
Mm,
it's remarkable, right? And it's
yeah.
exciting. Growing up here and seeing all the events that we've seen, whether of course it's KD leaving, we all know Kevin Durant broke our heart,
Yeah.
but then
Yeah.
seeing the team getting broken down, letting Russell Westbrook and trading Russell Westbrook and
Mm,
Paul George, and we
yeah.
did suffer a lot of losses. Just 4 years ago, we
Mm,
lost about 60 games, close to 60 games. But here we
yeah.
are, and resiliency is key.
Yeah.
And I
Mm,
think it's a really an inspirational moment, not just for our city, but just
mm,
across our country.
yeah. Yeah. This resiliency in showing that no matter what hardship you can go through, you
Hmm.
can make it out of it. Not only that, that is inspiring the next generation, just like you. You were
Yeah,
inspired by those who took it upon themselves to work through and see and help and be the light in that difficult circumstance at that time, right?
yeah,
And
yeah.
then another point that you talked to, which speaks to resilience, is that you kept your passion and you really worked to become a doctor, even, having to go through it 3 times of the application process and
Yep,
cycles. I know
yep.
that's never easy and it's so discouraging, disheartening when your passion is,
Mhm.
to do that and yet you still pursued. So that gives hope to a lot of other people out there who may be facing similar situations, right?
And that's my hope is
Hmm.
when you don't get in the first time, it's not the end of the world, right?
Hmm. Yeah.
The key is if you love this enough to where this is what you want to spend the rest of your life doing, you have to be
Hmm.
able to be willing to face those setbacks, and then that happens sometimes on a day-to-day basis, right?
Yeah.
There's days when I'm just like, what am I doing? I'm not doing the best that I can. And then there's days when I'm like, oh, I got this. This is a piece of cake, right? But you can't let the bad days ruin your passion, and you can't let the
Mhm.
good days let you forget what you're doing this for, right?
Yeah.
And so my hope is that sometime down the road, when they make a movie out of my story, we'll see, sometime down the road.
Yeah.
But my hope is that people really understand, if this is what you want to do, you can't look
Mhm.
back. There's only
Yeah.
one direction and one way to go, and that's
Mhm.
forward.
Yeah. Yeah. And you have accomplished a lot. And it's just because someone's has to try 3 times to get into medical school, so it doesn't speak to any level of that individual person. It just
Mhm.
shows that there's a lot of people you're competing against. You just have to try harder. Because I mean, looking at your accomplishments and things, it's just incredible what you're doing and what you've done in your life so far.
Yeah.
Speaking to that, with certifications in internal medicine, obesity medicine, MBA, MPH, what drives you to pursue knowledge across so many disciplines?
This is what I would say is, right now it's an addiction. And what I mean by that is when I started into medical school, I thought medicine was just the art of diagnosing and treating.
Mhm.
But the more I progressed through my training, and once I got into residency, I realized, oh no, that's just not what it is, right?
Mhm.
Math was never my forte, which is also one of the reasons why I got into medicine. But what I realized is, in residency, is this is what math is a big part. The finances are a big part. This is what really drives how we conduct practices, right?
Mhm.
And so I knew right first year into residency, I realized, okay, I need to learn the business side. And that's one of the reasons why, once I got out and once I was done with my internal medicine board, I decided to get an MBA. And so I did it. And it was great. I learned a lot. It wasn't easy being a full-time
Mhm.
doctor and trying to get an MBA on the side. But
Yeah.
then the more I learn about medicine, whether if it's quality, whether if it's managed care, I work with the Life Care Accountable Care Organization that Norman Regional is a part of, whether if it's understanding business development and strategy, and then trying to understand process development with Lean Six Sigma, and now looking at health data management and artificial intelligence. Anything and everything that I do, that I learn, is going to make me a better physician, a better physician leader, but also being able to manage and taking care of my patients better, right?
Mhm.
And so the more I learn about something, the less I feel like I know, but also it drives me to want to learn more. Okay, so what more knowledge can I accumulate to
Mhm.
become a better physician leader, but also to become a better physician and provider for my patients? Why would artificial intelligence be a big deal? Well, because I could efficiently see more patients, right? Why would health data management be a big deal? Well, because I need to understand how my patients' data is acquired, how it's stored, how can I access it, and how do we make sure that people that shouldn't have access don't access it, right? These are all important facets of healthcare. Privacy is a big aspect of healthcare,
Mhm.
right? So I think the key is taking it one day at a time and understanding that there's going to be days when you're going to find something that you don't know, and then knowing and realizing that whatever you're learning is for the greater good. And I don't think it's for everyone. I think there's nothing wrong in totally saying, I made it, I'm done, I'm tired of school, I'm tired of learning. But we're in a field where learning is essential. And some things that we know 10 years ago, we don't do those anymore, right? Just
Yeah.
today, I was reading an article on Doximity about restless leg syndrome. A lot of times we use dopamine agonist. Well,
Mhm.
now I believe the sleep guidelines are saying, well, we shouldn't be doing dopamine agonists. We should be addressing other sleep hygiene patterns. We should be
Mhm.
looking at iron levels, right? I wouldn't have realized that or known that unless if I took that 2 minutes just sitting down and reading that Doximity article just on my
Yeah.
phone. So it's essential. We have to be accustomed to living in a culture of everlasting learning, and that's just the way it
Mhm.
is. But I know that's difficult, and I think that finding the right balance is the key. I feel that I have for now. We only have one son now, but if we have another child, it might be a little more difficult. but I enjoy it, and I enjoy it because to me it's an addiction. I want to learn. I have that drive to learn, and I feel that learning knowledge, acquiring knowledge, makes me just a better overall person.
Yeah, that's very true. I mean, medicine itself is such a ever-changing field
Mhm.
that if you stop learning, you're not going to be able to treat patients at all
Yeah,
properly. Yeah.
no, no,
And so,
no.
but just in general, the way that you're, um, pursuing MBA and talking about leadership and health data management and things like that, that's a lot of extra learning.
It is. It is.
But it is also speaks to, individual passions and goals for the future,
Hmm.
things like that. Everyone has a different goal in mind sometimes, right? But learning also helps expand your perspective in life and understand um, different perspectives, different ways of doing things. The more that you learn, the more that you expand your knowledge, right?
Yes.
Versus just keeping it just one way. I think that's huge in general, just to have that ever expanding perspective, ever expanding range of being able to understand, being able to learn also is a something that people have to learn is how to learn, right?
Hmm.
And how to have that desire to seek knowledge. Um, and so, speaking to your experience in obesity medicine, just because that's kind of a huge topic in general,
Hmm.
and like what systemic barriers still get in the way of effective obesity care? And given that you practice in Oklahoma, specifically in communities like Oklahoma, and a follow up on that is how has GLP-1 meds helped or hindered your care for patients? What are
Hmm.
your thoughts on those compounded and the compounded GLP-1s as well?
Sure. So let me first start that off by saying about talking about GLP-1s, right? GLP-1s have really transformed the way that obesity management is done.
Mhm.
They have single-handedly put bariatric surgery in some places just out of business.
Yeah.
We have had to realize now this complete operations cost, operation marginalization issue, where which is more affordable, hiring a surgeon or just hiring a few primary care providers and learning to medically manage obesity, right? And so oftentimes healthcare systems are going the medical obesity management rather than surgical, and
Mhm.
also because you have to do quite a few surgeries in order to meet that cost. And
Mhm.
so GLP-1s, I've used them since I've started practicing. I actually think that they have a lot of benefit. I am on the side of GLP-1s having a lot of positive attributes.
Mhm.
I'm on one right now, and so I am a little bit biased. I don't own any stock or anything in any of the companies, but I am on one of them. I'm on Zepbound, and I've done really well. I've lost 25 to 30 pounds with all the being a new time dad and,
Yeah.
and being a full-time doctor, exercising, working out, nutrition. Let's face it, that does not come easy. So I've done really well on Zepbound, and so,
Mhm.
but not only that, even if I look at all my the patients I've utilized GLP-1s on,
Mhm.
they have done remarkably well. Now, it is not for everyone, obviously, and it's not a magic pill. You just don't take the injection and expect to lose 40 to 50 pounds
Yeah.
overnight, right? It takes time. You still
Mhm.
need to exercise. You still need to watch your nutrition. You still need to focus on muscle building, strength training. You have to do all the things. What it does do is it makes it easier to some extent. That's an oversimplification, but that's what GLP-1s do.
Mhm.
Have I used compounding? I have, and I'm not going to give out any real examples of my patients here, but let's just take a hypothetical situation. We have a patient that is 40 plus, has history of mental health disorders, and is not known to carry an insurance, is not known, and does not have an insurance policy that covers GLP-1s. Well, what do? They're not diabetic, so we can't really put them on Ozempic. We can't put them on phentermine because of their mental health issue, usually anxiety or schizophrenia or bipolar disorder. We can't do Wellbutrin because they're already on some other antidepressants.
Mhm.
And we need them to help them lose weight, because statistically, and studies have shown, obesity does lead to worsening mental health conditions, right? So in the long run, compounding, in my case, has always been used in those kinds of rare situations where I know that obesity is an issue, but what am I supposed to do? I'm not going to just sit on the sidelines and not do anything. I would rather find the reputable compound pharmacies and utilize compound medication in those kind of situations, and that's what we've done.
Yeah.
At least until the FDA came out and said no more compounding tirzepatide, no more compounding semaglutide. So that option is gone now. So people now are going to have to either pay out of pocket, or we're going to have to find another means of getting them covered, which is seeing if they have type 2 diabetes, seeing if they have coronary artery disease and or peripheral arterial disease, or seeing if they have sleep apnea and they're compliant on a CPAP machine. So those are the indications that you're looking at for insurance coverage as of right now.
Yeah.
When you're looking at barriers, especially here in Oklahoma, coverage, insurance coverage, insurance coverage, insurance coverage. That is the main barrier right now to obesity medical management in Oklahoma and across the country. Obesity, just because you have a diagnosis of obesity doesn't mean you're going to get this covered. A lot of times, a lot of insurance policies don't even have weight loss GLP-1s on their formulary list. That's just the way it is, because a lot of insurance companies are hesitant about the costs associated, the acute costs associated with GLP-1s. No one really takes into account the long-term benefits that we have of addressing obesity right now. And that's the sad part in our country. If we address obesity now, what are we looking at in terms of cost savings 10 years down the road? A lot of studies have been done, and they do show cost savings. There is variety in how much, but at the end of the day, we know that obesity is an issue. We know that it can lead to various other medical issues down the road, whether that is cancer, heart disease, diabetes, dyslipidemia, mental health issues, well, I wouldn't say osteoporosis because that's actually a protective factor, but osteoarthritis. We know that obesity is a big issue. It's just we just don't have the leadership in wanting to right now in our country. We don't have the leadership necessarily to sit down, talk with the pharmaceutical industry, find ways in which we can, and the insurance industry, and find ways in which we can actually get these approved. Because there's a lot of benefits right now that are being studied for GLP-1s, whether that is schizophrenia, whether that is cardiovascular disease. We already have Wegovy covered for coronary artery disease, peripheral arterial disease. They're looking at alcoholism with Zepbound. We've already have Zepbound covered for obstructive sleep apnea. I mean, the sky is the limit, and we're not even truly, we're just at the beginning of the GLP-1, what I call the GLP-1 revolution. Sometime later this year or next year, they're supposed to be coming out with ritutride, which is supposed to be a triple agent therapy, GLP-1, meaning not only does it look at GLP-1s to reduce appetite and GIP to reduce gastric emptying or keeping you more full, it is also supposed to act on the glucagon receptors to help with muscle wasting. So just imagine the benefits of that, and what we could do if that was available to a greater segment of the population. 2023 was the first time when the United States was able to decrease the obesity rate, even though it's only by like 0.1 or 0.3%. GLP-1 actually played a big role in that, and we need to find ways to get more people on these medications. Compounding has its risks. I'm not saying I'm pro compounding. I'm not. But one thing you cannot deny with compounding is that compounding actually brought down the cost. There's a reason why Eli Lilly had to create the Lilly Direct Pharmacy and brought down the cost of 2.5 milligram vial dose of Zepbound from $1,000 plus to $349 a month because of compounding. So that's where compounding really played a big role in, and we can't deny that particular aspect of it. Were there pharmacies and other places that were not necessarily selling a product that was studied well? Absolutely. No one can deny that. But if you found the right reputable compound pharmacies, and there are a few out there, I'm not going to say any names, but there are a few that we've utilized that we've not had any issues, that we actually thoroughly researched, and we found that they were actually doing it, producing and storing according to FDA guidelines. And those are the pharmacies that we've used. And so it is a surprise that the FDA has decided to ban compounding. I didn't think that was going to be the case. But once, what's that company called? Hims and Hers put that Super Bowl ad out there.
Right.
That was the final straw. And that was, I think, when everyone realized this has a lot of money in it. we need to stop this now before people start profiting, like massively profit. And some people have already, and there's no shame in accepting and admitting that. Some people, whether if it's some of the med spas or places like Roe and Hims and Hers, they have profited. But I think that was the last straw, and that's when the FDA really said, okay, this is it. We got to stop this. GLP-1s are amazing. I know that they're not for everyone, but I do feel that there's going to be so much more that we're going to learn here in the next couple of years, that I think that the idea of just obesity medicine certified doctors prescribing it is probably going to be gone. We've already seen a lot of primary care physicians using them and utilizing them, but I think they do a lot of good, and that's why I would really like to see increased insurance coverage for these
Yeah.
medications, especially here in Oklahoma.
Mhm. Yeah, I totally agree. I think like the fact that there is an obesity epidemic, and yet there has been societal negative
Hmm.
imagery of GLP-1s, which kind of hinder a lot of patients also from, they feel ashamed when they take it sometimes,
Hmm.
instead of it being a positive thing for them.
Hmm.
Because it, as you said, there's so many benefits and long-term benefits on the health system in general too, when you're helping patients now in their health to decrease the greater adverse issues they will have later on down the road if they don't correct their issues now. And a lot of patients don't have that ability or the lifestyle help to counter their obesity without this type of medication help to kind of jumpstart the process, so to speak.
Hmm.
And so that's really interesting to see, and kind of sad, really sad to hear how, we're not really taking advantage of these medications for the benefit of the greater population. Instead, we try to manipulate the financial aspects of it instead of creating a healthcare goal, right?
Hmm.
And so, where do you see opportunities for more equity in access, education, or treatment when it comes to these chronic disease management?
In the United States, I don't think we've ever abandoned chronic disease management. I think
Mhm,
we've always done a good job. For example, heart disease has actually gone down in prevalence.
mhm,
Certain types of cancers have gone down in prevalence. We're trying to address the obesity epidemic with research that's been conducted in the last 2 decades that have led to GLP-1s. So we
mhm,
have done a lot on chronic disease. So this idea that for some reason we've abandoned it is not necessarily, I don't necessarily think that there's a lot of validity out there, because you
mhm,
have the outcomes, we have the data that shows we made improvements.
mhm,
I think here in Oklahoma, and of course in the United States, we have to do a better job of addressing mental health. Mental health is such a need. Mental health is such an issue. For the waiting time to see a behavioral therapist is 3 to 4 months, unless if you go online and use one of the online therapy services. The waiting time for a psychiatrist is 3 to 4 to 6 months, depending on what part of the state you're at. Even I myself, at one point, and again, this is just me and my extracurricular intellectual curiosity, I actually thought about enrolling. UC Irvine actually has a primary care mental health certification that we could do. And I even thought about doing that just to learn how to
mhm,
be a better mental health provider and not have to rely on psychiatrists. So, for opportunity, we have to do a better job of investing in mental health in Oklahoma. I know that for a while that the state government did announce that they were spending more money building a new Griffin Memorial location in South Oklahoma City, around the OSU OKC campus. I know that's kind of put on the side now. Opening was supposed to be 2026. The building hasn't even started constructing, so who knows? But I was really hopeful at the time that perhaps this was the time when we were investing finally in mental health. And I don't know where that's going to go, but that is something we need to do. We need to learn how to build more, develop, or grow more psychiatrists that would like to practice here in Oklahoma. Right now, Oklahoma has 4 psychiatry residencies, and I don't know what the number of doctors that they train together, but it's probably somewhere around maybe 45, 50 together per year. But that's not enough. We're a state now that's over 4 million. And so how are we going to address this? And so developing more psychiatrists, incentivizing behavioral therapists, incentivizing people going to behavioral therapy school. We need to do more of that. And how that goes about, I'm not 100% sure at this time, but money is the key. Money is the key. The other thing I really, really thought about is psychiatry is a field where telemedicine has really made a significant impact on. So, but one of the issues is learning how to utilize telemedicine services from out of state. We're close by a big state, Texas. Perhaps maybe we could find some sort of motivating factors for people in neighboring states that have done somewhat of a better job, perhaps, in investing in behavioral therapy and psychiatry and using telemedicine. But again, these are ideas. We need to put them into play. So mental health is something we have ignored, and mental health is something that we need to address. And the pandemic has shown that significantly. And now the issue is it's fallen upon primary care, and it's not that primary care is not adept. That we are. It's just the issue is it's so prevalent, and at times it's very significant that the training that we receive, I believe, is not sufficient. We're here to address the basic moderate chronic mental health illnesses, but the severe ones, I don't think in family medicine, internal medicine, or pediatrics, there's just not enough time at this point in training to really address that.
Yeah, it's huge. The problem with anxiety, depression, mental health illnesses, it doesn't even have to be, schizophrenia or like any major mental health issues. It's just people are more anxious, more prone to depression in general. And that can lead to worsening mental health crises and difficulties and chronic issues. And as you said, that's not really well addressed here currently. Whereas you're correct in saying that we have made strides in chronic disease management through public health measures since decades. Definitely, the public is more adept in understanding coronary artery disease and prevention of that, simple basic diabetes preventions, or understanding those different lifestyle changes that because of public health measures that have been initiated over the decades. But yeah, what are we going to do about the mental health crisis currently? And 2020 really highlighted it being a huge issue due to society, the work-life balance or lack of it, and so many factors, loneliness, community, lack of community. I mean, there's so many factors that, have to be addressed in order to kind of correct and hopefully get us back on track. But I think even just there's in general a physician shortage, across the board. And how do we get people back into med schools? But that kind of brings up another topic of the financial barriers to even medical school. Like I have on the podcast talked to at least 2 PAs that applied, got accepted to med school, decided not to do med school, went the PA route. There's just a huge financial burden on doctors with the loans and everything. And now they're trying to talk about capping the amount of student loans you can get, which I think will make it even worse. I mean, no one wants to be burdened with student loans, but yet a lot of people can't afford it.
And so I've thought about this. I've spent a lot of time kind of coming up with my own ideas. How do we address this? So if you look at how modern medicine is practiced, right? When you have primary care and specialists, but even on the specialist side, you have APPs, right? You have APRNs and PAs that work with endocrinologists, cardiologists, and oftentimes it's the APPs that tend to see the patients that primary care refers, right? Refers over to the specialist. And so the question that I've had, and this is a little bit controversial, and I don't know if I should be saying this, but as physicians, I don't think we're really good at advocating for ourselves, and that is a common belief. And I don't really know why that's the case. I don't know if it's everyone's competitive, everyone wants to be cream of the crop, or I don't know if that is just because we're so diversified into multiple specialties and we just can't come together once as, for the sake of all, I guess, physicians. I just don't really know why that is. But look at the number of years that medical training in the United States takes. If we have another pandemic, we need to produce more intensivists. That is a 10-year process from the day one in medical school to the day that they're done with fellowship, and then the day that they get credentialing and we're ready to be intensivists. You do 4 years of medical school, 3 years of internal medicine residency, followed by 3 years of pulmonology, plus another 1 year possibly if they want to do something, if they want to do some subspecialty. That is incredibly just ridiculous. I, as an internal medicine doctor, physician, I understand why why I did 3 years of internal medicine residency. That makes complete sense to me. If I was a GI doctor, I am not really going to focus on treating someone's anxiety and depression. There is no reason why, and again, some people might get upset, but there's really no reason why someone that wants to do GI and they know they want to do GI and they know they understand this is what they want to spend the rest of their life doing, there is no reason why they need to do 3 years of internal medicine residency when they're not probably going to even touch depression or anxiety during the course of their practice, right? And I think it goes back to what is the point of really using all these years when you really don't necessarily utilize a lot of what you learn in medical training if you're a specialist or a subspecialist, right? No one's going to look at the Krebs cycle that you learn in year one of medical school and try to treat someone. That's not the way it works. And so the way that I thought about it was, if we really want to address how we can get more people to get into medicine, reduce the number of training of years. You really don't necessarily need to spend a whole decade of your post-adult or your adult life in school, in training, because a lot of that is not something that you're going, whatever you learn during that time, you're not going to necessarily utilize that on a day-to-day basis. And so the way that I thought about it was getting rid of fourth year of medical school, because a lot of people just interview for residencies and prepare for a match. And of course, cool down a little before residency starts, maybe take out 1 year, the third year of internal medicine or family medicine or any other primary care residency that you're looking at. And then maybe cut 1 year of fellowship to 2 years. So then you're basically reducing that by 3 years. And yes, that's still 7 years. But I do think that is sufficient amount of time to ensure adequate training, and it's also sufficient amount of time. That's 3 extra years that you can actually end up making more as an attending than rather than living on a fellow and a resident salary. And people forget, as a resident and fellow, you're making 50, 60 grand a year, depending on what part of the country you live at. With the way cost of living is now, that is not necessarily a sufficient salary to live, a fantastic, wonderful lifestyle. You still have to be wary of what you spend and what you save, right? So that's the way that I thought about it, and I still to this day don't really understand why it does take that much amount of time really to undergo medical training in the United States, other than, let's face it, hospitals need labor, and perhaps maybe that's the reason why. But we actually have to do something about this, because to take a decade just to put out a pulmonologist or even an infectious disease consultant, a specialist, that takes 9 years. That's just not a great way to keep up with the labor force. And I'm not surprised that your other guest got into medical school and decided to do PA. Who knows? I mean, down the road, more people might want to do that, and I don't blame them. Why would you want to spend a decade of your life working hard, working 80 plus hours a week, not really making that much money? I mean, technically, a resident in the United States, a resident physician or a fellow physician in the United States makes less on an hourly basis than someone working at Starbucks. That's a fact. And so why would you want to do that? I get
And
it.
you're paying off the $300,000 student
Yep.
loan
Yep.
while earning that. Yeah, it's difficult. So how does it like differ from those who do medicine in Canada, UK, Australia, other parts of the world? Because I know theirs
So,
is different and they have the MBBS and
mhm. So one of the things is that there is some postgraduate training, and it varies from different part of the world. Australia is
Mhm.
different than Canada,
Yeah.
and but the I think the way that they're able to do it is number one, cost of education
Mhm.
is most likely nowhere near as expensive as it is here. And I could be
Yeah.
wrong. Some places it could be, but two, the postgraduate training is nowhere near as intense or as time consuming. I wouldn't say intense, but nowhere near as time consuming as it is here. And so with that, you're able to your labor market is just able to pick up a lot more quicker, and that makes a difference. Now, one of the things that we always hear about is in Canada, well, you have so much of a longer time to wait to see, a specialist or a primary care provider. Well, absolutely, that's everywhere. I mean, even here, right
Yeah.
now in Oklahoma City, if you want to find a primary care provider, your
It's
wait,
6
unless it's
months at
someone is
least.
starting new, is going to be 3 to 4 months, right? Right
Yeah.
now, I have a 5 month waiting time.
Mhm.
And I've started 4 years ago, and I see on average about 80 to 90 patients a week.
Mhm.
And so it's hard. I get it, but the other countries have just done a better job of understanding that concept of putting out healthcare labor force is important, and the length of training is not necessarily something that may always correlate with the competence, right? That doesn't mean someone can just do a year of medical school and then your residency. I understand that time it takes time to develop the skills, and I get that part. But at the end of the day, spending a decade or 11 years is just is not sufficient, and especially with the retiring baby boomer population, and
Mhm.
especially with the burnout that we've seen after the pandemic,
Yeah.
especially all my friends saying, "Hey, man, I'm ready to be a stockbroker. I'm probably gonna peace out here in 5 to 10 years."
Yeah.
It's frightening. Where we are really seeing, and I'm not trying to cause a panic or alarm, but the healthcare industry right now is reeling in this country, and there's a lot of different factors to it, and we can address them together. But the problem is we need to come together as a nation and understand why things are done, and how to do things the right way. Yelling and screaming and name calling isn't going to get us anywhere, but coming up
Mhm.
to real solutions together is what's going to do it. You mentioned capping student loans. I don't know how anyone can afford medical school if that is capped at that level. That's going to be really hard. Private loans are not easy, and private loans you have to pay, right? You
Mhm.
can't necessarily defer them, and that means less quality of life and residency training and fellowship training. There's a reason why international medical graduates tend to pursue more likely to pursue fellowships, and that's simply because they don't necessarily have the medical student loans that domestic or American medical graduates do. That was a factor in me. I didn't want to necessarily go through HEMONC, even though I built a research profile and tried my best. But one of the reasons I didn't want to do it is why would I want to spend an extra 3 to 4 years working at a poor salary while trying to settle down at the same time with family? It
Yeah.
would have been hard. And how we go about doing that is by reducing that number of years of training, and by not by capping student loans, but by generating some kind of incentive, public loan forgiveness, do more public loan forgiveness options.
Mhm.
Follow up on how to keep interest rates low. Right, 6.5% right now is the interest rate for a federal
Mhm.
student loan.
Yeah.
That's a lot. That is
Mhm.
still a lot. Do we really need to bill at that high of an interest rate? I don't know, but I don't think that's sufficient. But I don't think that's the right thing to do. But we'll see. We'll see where things go. But right now, the healthcare industry really has to come together, and especially physicians, and we really have to advocate for ourselves. And a lot of that means putting aside differences and coming together. And I don't know if that's going to happen this year. I don't know if that's going to happen ever. but that has to happen if we want to fix our problems.
Yeah, for sure. Coming together, not just for advocation of the physician's
Hmm.
practice, but also healthcare in general.
Yeah.
Feels like there's an assault on healthcare and navigating the healthcare system, being able to treat patients being able to feel like they can get proper care. Um, and a lot of people have to come together and put aside differences to really think about what are we doing here.
Hmm.
Um, and as you said, also burnout has been a huge thing lately among healthcare providers. And that's what I've been seeing a lot of in discussions with other healthcare providers out there. And yeah, everyone is tired of the current healthcare system, even as providers, not just the patients, but the
Yeah.
providers themselves. And so, I mean, you are practicing physician, but also now a new parent and demands of being a provider. What kind of tension have you felt in that this season of life, and how are you navigating it? How are you preventing burnout, or are you able to prevent burnout for yourself?
It's it's definitely a challenge, and
Yeah.
it's not as hard as I thought it would
Mhm.
be, but it's still hard. Uh,
Mhm.
there's priorities change. Number one, you're no longer the number one priority, right?
Mhm.
It's the baby. And when with our son, he was about 7 weeks premature. Actually, my wife's water broke at 32 weeks, and so we spent 2 weeks at Children's Hospital. And then the night before, of course, I didn't sleep those 2 weeks, so I was really nervous. I didn't know what was going
Yeah.
to happen. We didn't really know how serious, the condition was, because he also had a little bit of some growth restriction. And so even the night before he was born, I was up all night. And this is when maybe knowing too much is also a bad idea, because I was looking at the
Mhm.
tachometer and I was like, oh, I was texting my brother, who's a family medicine doctor. I was like, hey, look, this looks like it's a variable decel. Is this a good thing or a bad thing? What do we do? And he was like, just go to sleep. It's okay. And I just couldn't. And
Yeah.
so we had to deliver him via C-section. My wife had a little bit of some issues with the epidural that was given. Her blood pressure
Mhm.
tanked, and we had to put her on fluids, and then we just had to say, all right, let's just do a C-section. And man, those 2 weeks were so rough, not really knowing what was going to happen, worrying about my wife's health and the baby's health. But when I first heard his cry, there's such a huge sigh of relief. Oh my gosh. Okay. So we heard the cry, and then now we have to see what we're dealing with. And that unknown, the
Mhm.
uncertainty is a very, very, um, it's powerful, but
Mhm.
it also is very frightening. And so as soon as he was born, we took him up to the NICU, and I'll never forget this. And the NICU attending at Children's, OU Children's, they were fantastic, the entire team. But the NICU attending, after 5 minutes, they were examining him and started feeding him, and then the NICU attending just kind of patted me on the back, and he said, all right, doc, we're good. I'll talk to you later. And I was like, wait, what's happening? Like, what's going on? Like, how is he? And he's like, well, doc, you have a baby that breathes on his own. You have a baby that feeds, and you have a baby that poops. You're good. So he is a little bit underweight. He was about 2.5 pounds when he was born.
Oh.
And then we'll worry about the weight later. And that was it. And he had to spend another 3.5 to 4 weeks at NICU and OU Children's, and they took really good care of him. But that was a very difficult start. And so having to balance that while being a full-time primary care provider, it's hard. Luckily, I have to thank Northern Regional for not pressuring me to come back to work. They said take as much time as needed. You take care of yourself, your wife, and the baby. I have great colleagues, of course. One of them being my own brother, but we also have some amazing nurse practitioners, and I have great nursing staff, and they've all done a good job of covering for me when I was really not even thinking about work. And so being a full time doctor and being a new time dad is hard. There's challenges. There's oftentimes some a little bit of back and forth. How do we get the baby to stop crying? What's going on? No matter how good of a doctor you are, even if you're a pediatrician, uh, if it's your son or your daughter, you're going to feel some degree of anxiety over why is the baby crying, what's wrong, and again, sometimes when you know too much, it's not always a good thing, right?
Yeah.
We've even got him a pulse ox. That's how that's how I mean that's the extent that we went, just because of our first him being our first son, our first baby, and then also him being premature. We have really been, I think, in some cases maybe a little bit over precautious. But it's hard, and if there's anyone that's going to be a father soon, it's a great experience. It's a great job. I love it. Every time I come back home after 5 p.m., I try not to open up, my computer until maybe a couple of minutes before I'm going to bed, because that kid deserves your attention. You're a father now, and you need to make the time, the dedication, and you need to understand that balance, the balance between work and the balance between family. People will, 20 years down the road, no one's going to remember if you're 5 minutes late to work, right? But if you miss that child's soccer game, or if you miss their birthday, or if you miss something in their life that's memorable and eventful, the child's going to remember it. And that's what I've learned, is I need to be there as much as I can be. I am a doctor, but I'm also a dad, and learning that has not been easy. Balancing that, I'm not going to lie, has not been easy, and it's not going to be easy. It's going to be hard, but you have to learn how to do it, and that's just the meaning of life, right?
Yeah.
You can achieve all these accomplishments. You can achieve certifications, honors, money, everything. But that's all second to family. That's all second to being a husband, being a son, being a brother, and being a father. And of course, an uncle here and soon. But at the end of the day, when you're a dad, you're dad. That's it. That's your baby, and that's your son or daughter, and your job is to be there for them when they need you the most. And sometimes that means a lot more than you want to, but you
Yeah.
have to learn how to do it, and that takes time.
Hmm. Yeah, it's so important. We get so caught up in work, and work, especially in medicine,
Mhm.
creeps into home life so easily.
Yeah,
And so it's making sure we have that separation and the ability to say no
yep,
and have that boundary established. Otherwise, um, it creeps.
it does. It does.
Yeah. And so, and speaking of your wife, how or what's something your wife Namrata has taught you about support and strength that's helped you both in fatherhood and medicine?
I always say my wife is my biggest accomplishment, right? And I'm
Mhm.
fortunate to have found her in my life. She has really taught me that balance. And I see myself as someone that wants to constantly get better, constantly
Mhm.
learn, constantly do this or that. And I think what I've had to do is cut back on it. And that is hard to do,
Mhm.
but I think that was only possible with my wife really showing me and telling me this is what you're here for, is not just having your own set of records or your own accounts, but it's here to enjoy these little moments. And I wouldn't have really been able to understand that without her showing me and telling me. And it's not easy. And one of the things I will say about being a father that I've really come to appreciate more, and I've had co-residents that were pregnant, that were new moms during residency and even in medical school. But once I kind of saw what my wife went through, it's not easy being a mom, and so I've really come to appreciate motherhood more. I've always respected it. I always knew that it was difficult. But when you really see your loved one, the love of your life, going through that journey, and it is difficult. There are struggles, but I really came to understand and appreciate that more and more after I saw her and what she has done a remarkable job of obviously taking care of our kid. But it's not easy being a mom. It's not easy being a dad, but it's not easy being a mom. In some cases, it's not easy more being a mom. And so she really has been with me every step of my journey so far in medicine and now as a dad. But I also know that it's because she's strong, and I also know that's because she really cares for me, and she really cares for our son, and she has had to make sacrifices, and that's hard to do. And I think that's what a lot of working moms, or any mom, not just working mom, and any mother does. And so motherhood is something that I think I've gained a lot more appreciation for. And I really would like to say this, and that is that maternal leave in this country, there's not really any consistency, right? And then we need to do a better job of that. We need to do a better job of giving moms the time and the space, not just for their own sake, but even for the baby's sake. It's important for newborn babies to have that connection with their mothers. And so we do need to do a better job as a nation and understanding the importance of maternity leave. I know 90 days is often what's always given, but in my case, there's nothing wrong in expanding it, and it's essential. And who knows, maybe we'll look into it down the road, but that is something that we really need to think about as a nation.
Yeah, that is very true. Especially just for as you said, the child's health
Mm-hmm.
and wellness, that bonding with the mom and dad in that first year is so critical.
Yeah.
And so necessary. And yet we're expected to leave them and, go back to work.
Yeah, and show up to work, and then
Yeah.
just try to be just as like it was before, and it's not. It's
Yeah.
not easy.
Mhm.
And so I think it's something that we really have to do a better job of.
Yeah. Yeah. Speaking of creating different cultures, how can leaders, especially those with both clinical and administrative experiences like you,
Hmm.
create cultures that prioritize wellness and team connection, things like that,
Yeah.
in the healthcare setting?
I think the key to organizational culture, there's two things
Mhm.
to look at. Number one, you never want to create a culture of fear. People should not be afraid to speak up. People should not be afraid to voice their opinion, right? Once you do that, you really lose the ability to improve the organization. You really lose the ability for constructive feedback. In residency, I've had in residency in medical school, a lot of people yell at me, scream at me. I'm pretty sure you've had that too during PA school. But the moments that I had people sit me down and say, "Hey, this is what you're doing wrong," in a constructive way,
Mhm.
I've really learned more from that than anything else in my life. And so when you create a culture that is not based on fear, when you create a culture that is based on openness, improvement will always be there, right?
Yeah.
The other thing that we really need to look at is creating a culture that is based on merit. You should hire someone not because you know them, but because of what they know, right?
Yeah.
That's the key. And when you create these two aspects, a culture that is not based on fear and a culture that is based on merit, right, when it comes to hiring, you can retain better. And when you retain talent better, your organization is going to continue to grow, right?
Mhm.
And that's the key. And so for anyone that's looking into getting into leadership, understanding those two concepts are very, very important.
Mhm.
The last thing I always tell people to look at is an aspect of positivity. Uh,
Mhm.
People should not want to come to work dreading it. Oh my God, I'm coming to work. Oh my God, someone's going to yell at me. Oh my God, this is going to be the worst day of my life. No, 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 no. What you want to
Yeah.
do is you want people to understand you're there as an
Mhm.
employee for a purpose. You want to give them a purpose. You want to give them the tools to succeed. And you want to make sure that you let them know that their voices are being heard. And that's key. So when you do these three things, you really can build an organization that can face any challenge. Guaranteed, that doesn't guarantee 100% success rate, but it does guarantee that you can build a long-lasting organization. When we look at, one of the reasons I really got into an MBA was because I wanted to learn more about organizational cultures and looking at adaptability. when you look at Kodak, right? Kodak for all of the 20th century, photography and Kodak were synonymous. You could not
Mhm.
find any photo company that
Yeah.
was as prevalent as Kodak was. But because of their poor hiring choices, because of their inability to adapt, they eventually now we don't even know. I mean, the kids don't
Yeah.
even know what Kodak is. Growing
Yeah.
up, that's all we heard of until
Yeah.
the 2000s, until the advent of digital photography.
Hmm.
But that's the key, and it's really coming to understand that creating a culture that is not based on fear, retaining and hiring and retaining talent, and having a positive environment. Those are what you really need to work at. And that takes time, that takes experience. But if you are able to master those three ideals and concepts, you should be really good at creating a long lasting organization.
Yeah. I think that also, having a leadership
Mm-hmm.
team that allows for that communication, that allows for that constructive feedback
Mm-hmm.
instead of fear, encourages accountability. And accountability is critical in allowing the team
Mm-hmm.
to fulfill their duties 100%.
Yes.
Because if there is no accountability, then something's going to fall through the cracks and nothing's going to get done properly at all.
Exactly.
But you have to have that trust with the leadership team for the other team members to be able to say, like, I'm going to do this because I want to, for, first of all, and then not because I'm just going to be negated or, no one's going to follow up or I'm just in fear. But yeah, and so
Mm-hmm.
that ability to have that proper accountability.
Mm-hmm. Yeah,
Um,
accountability is something I think that is often understated.
mhm,
And unfortunately, I don't think we're seeing that a lot of these days. But when you just hear the news, and that's something that we have really lost, not just in politics, but just
mhm.
in all facets of life. Whether that is healthcare, whether that is the movie industry, whether that is the flying industry, right? With what Boeing is going through right
Yeah.
now.
Mhm.
And then that's key. That's important, and it can't be emphasized enough how important it is to keep people responsible for their mistakes, and help them learn, but also making sure that they don't repeat those mistakes, right?
Yeah. Yeah. I think it goes back to also the integrity of everybody on board
Hmm.
and having those character strengths. But I feel like character integrity sometimes are secondary to other characteristics that speak more volume but
Hmm.
have no basis.
Yep. And that's the sad part, right?
Yeah.
And that is the
Yeah.
sad part of even if you look at leadership in general. Um, and then this is something one of my mentors, Dr. Kamoga, told me. He was my program director at internal medicine residency at White River in Arkansas. When you're a healthcare provider, people really care who you are, right?
Mhm.
When you're a politician, they don't, right? People will still vote for you
Yeah.
depending on your criminal record, but when you're taking care of them, right? They do care, even
Yeah.
if that means that you have something as I wouldn't say minor, but something like a DUI,
Mhm.
or something even more severely criminal. It matters to them because
Mhm.
they're putting their care in your hands. But then when it comes to politics, it's like, oh, okay, well, it's okay. I mean, and I think that's where we tend to be okay with foregoing those flaws,
Mhm.
in the hopes that, okay, well, this person is a leader, and being a leader means you're going to have to do things that are not always of good character, and that's just the
That's
sad part of society, right? And
yeah.
it is what it is. So.
Yeah. And I mean that trickles down into workplaces too. I mean,
Mhm.
not
Yeah.
necessarily the providers, but those who lead those healthcare facilities or hospital systems or
Mhm.
whatever modal of medical practice.
Yeah.
The leadership may be different than the provider base, but I think that that idea, that concept that um, it's whatever everything is on the table as long as you get the job done kind of mentality.
Yeah.
That lack of integrity then trickles down and creates a whole lot of problems down the line.
Mhm.
But switching gears a little bit though to because I don't want to run out of too much time, and I wanted to get it a little bit more questions out of you
Yeah,
because
for sure.
you've earned fellowships in clinical medicine and health data management. And how do you see AI shaping the future of primary care and provider communication or practices?
So with AI, I know we always hear a lot, oh my God, this is the end of
Mhm.
medicine. It's going to be, we're going to be replaced by, AI and into doing primary care and other aspects of like medicine, whether it's radiology and so on. I
Mhm.
don't think it's going to be like that. I think it's going to be a matter of whoever learns how to utilize AI, they're just going to be more effective than the ones that don't. I think that's where
Mhm.
we're headed, at least for the next couple of decades, in my opinion. I don't necessarily think it's going to be, here's your new AI and it's your new primary care provider. I don't think we're there yet. I don't think we're ever
Yeah.
really going to be there. And the reason why is no matter how much how developed an AI is, it's never going to really be able to develop that empathy, that particular trust that you can develop with
Human.
a provider, a human provider, right?
Mhm.
I do think it'll force changes. I do
Yeah.
think you're really going to have to learn how to be a better communicator. I think you're going to have to learn how to show empathy, be basically wink, wink, better bedside manner. And we're entering what I think is an era of health consumerism more and more. People will do what they want, people will pay for what they want, and they don't want to pay for what they don't want. And AI is going to be a tool in helping us being able to do that more efficiently is the way that I see it. And I think it's going to be one of those aspects that medical schools are going to have to learn how to start teaching physicians how to utilize AI resources. And I don't know if that's going to be an easy concept to accept because there will be a concern if people are just relying on AI, will they actually learn the real stuff, right? That's going to be the
Mhm.
concern. And how they're going to balance that is going to be hard. How they're going to have to balance true learning versus just depending on AI. That's going to
Mhm.
be difficult. And then thank God I'm not in in academic medicine.
Yeah.
But you're going to have to look at some degree of medical training being dedicated to utilizing AI resources, whether if that is in medical school or residency, or even earlier, who knows at this point. But it's going to have to be done, and that's the future. You're either going to learn how to use it and be efficient, and of course, develop other good personal skills, or you're just going to sink.
Yeah.
Is really just the way that I think it's heading right now, and I think that's what it's going to do the next couple of decades.
For sure. I mean, we're already seeing AI implementation in efficiency of practices or
Hmm.
um, even, EMRs or, different things like that. You can, see implementation starting to try to get into there. But just for the efficiency's sake, as you said, yeah, I don't know how
Hmm.
it can take over the human capabilities of being a provider yet. Um,
Hmm.
but definitely introducing it to make, you know, admissions, discharges, hospital, or even just collecting data and managing that kind of data management or things like that, right? Is how
Hmm.
being utilized now that but we have to understand how it's being utilized, how to understand how we can um, create those better workflows with those AI
Yeah.
incorporations. And so, I mean, ethical, practical challenges with AI, there is a huge rush towards that technology now. Ethically in medicine, what do you think about that? At this time, do you see anything ethically that we're concerned about, or is it more for the future?
I think we will see some ethical challenges. I think there will be some roles that will be eliminated. The idea of scribes, right? Human scribes. I think they will be one of the first roles that are most likely just unfortunately eliminated. But that is with the advent of any kind of technology, right? This gentleman who used to be my barber, this was a couple years ago, he told me his story, and he got into becoming a barber because his first business got eliminated pretty quickly because of technology. And he used to be what was called the medical imaging transporter, meaning he would
Oh,
uh, drive and transport X-rays or CT scans from one geographic location to the other. And that was a thriving business before the internet in the 90s. And then all of a sudden, the internet came in. Within a year, he lost his entire business. So he had to make a career transition and basically went to cosmetology school and became a barber. So these are things that you're going to see. That's just with the
yeah.
advent of technology. We are going to see some roles being gone. And I think AI scribing is already here. It does a remarkable job. I have not had the fortune of using it, but I know how it works,
Yeah.
and we're probably going to implement it in Norman hopefully in the near future. But there's going to be roles that you're going to lose in medicine, and scribing is one of them. I also hope, and this is just me being biased, but prior authorization. Maybe that's something that we also may end up necessarily getting eliminated, because the concept of that is a little bit in itself wary. Most medical professionals these days, whether it's APPs or physicians, are trained to be mindful of cost and cost control. So I'm not really sure why the insurance company has to ask the provider again, are you sure you really want to do this? Well, of course I do. Why would I want to put that in, right?
Yeah.
But AI can probably help mitigate that situation. It could probably help eliminate that need and make it faster. And I don't think that I think there's one, if I remember correctly, there's one tool that might be coming out that I was reading about the FDA. Don't quote me on it, but that could be saved for prior authorization. But you're going to see losses. That's with technology, and I think that's just something that we're going to have to be okay with in medicine. And that's not just in medicine, though. There are concerns that that's going to be across the broad spectrum of society. There is some theory that by 2030, that 10% of the workforce will be unemployed because of AI. Whether that is true or not, we have to wait and see. But it does raise questions. How are we going to address that? And a lot of that just depends on the individual ability to learn how to transition to a different career, but also learn how to be motivated to continue to learn and acquire new skills. And that's something that's going to be difficult to do on a society basis right now with the limited resources we have. But that is something that we're going to have to look at, whether if that is 2030 or 2040. We'll just have to wait and see.
Yeah. And what is your leadership philosophy in one sentence?
That's a good question. One sentence is a little bit hard. I would probably say leadership is not about power, but is about empathy, listening, and knowledge. I think that would probably be my philosophy. Just because you're a leader doesn't mean you have power. Power doesn't come from a position. Power comes from the other three aspects. Empathizing with those around you, listening to them, and then knowledge, acquiring knowledge. That's the key.
And what advice would you give to early career physicians who want to lead but don't want to lose their soul and family along the way?
It's hard. You have to really learn how to balance both things, and balance is the key. And you also have to learn how to prioritize, right? There's a list of things that I want to do in the next 2 years. I'm not going to share it and bother you and bore you, but there's a priority to it. What do I want to do first, right? I'm signed up to try to get my certified physician executive credential. I'm doing a capstone with them in August. That's my first priority. I've gotten into this program called Leadership Oklahoma City, which is a community-based program here in Oklahoma City. I'm really excited. It's going to start in September. I used to be part of their youth leadership exchange when I was in high school. So things come full circle. So
Yeah.
that's a priority, right? I'm involved with the HFMA, and I'm trying to get the Certified Healthcare Finance Practitioner credential. That's a priority, right? But you kind of have to understand you can't do everything, and you have to choose what you want to do. And sometimes when you put too much on yourself, you have less chance of success. I also want to lose 30 pounds. Well, I don't know how that's going to happen, right? So, and we also want to take a trip to, to Disney World or to go on a cruise. One of those two. You can't have both. You have to have one or the other. Which one do you want to do? So, really, it's about learning to balance and learning prioritizing what your goals are. And as long as you're able to do the two, I think the sky is the limit. But it's hard, and you have to be patient. You're not going to be CMO the next day after you finish your MBA, right? There's more to it. Learning and acquiring skills is important. Waiting for your time and for the right moment and being ready for that moment. And that's hard to have patience, I feel, in our generation sometimes. But that's the skill that we really have to understand. And that takes time and that takes knowledge. And so the more skills you acquire, the more knowledgeable you become and the more confident you become in your abilities. And so learning how to be patient is key, and being able to prioritizing your goals and being able to find that balance between family life and career. Those are the three things that we need to really look at for early physicians.
Yeah. And what gives you hope right now in medicine, family, and the mission ahead? What gives you
Oh
hope?
man. Well, I mean, the Thunder won. That was a big deal. Right? That's a big
That
deal.
was,
That's a
yeah.
huge deal. I was a nervous wreck apparently in Game Seven of the race of my life, Game Seven of the NBA Finals. I think the hope I have is with family is that we have been through so much, my wife and I, whether if it's her getting stuck in India for immigration issues, and then trying for 2 years before finally getting pregnant, and then going through that challenging time with our son. We have been through a lot. So when you go through a lot of those events, you can really face anything together. So that gives me hope, and family. With just medicine in general, I don't want to sound hopeless. That's not the key. But I think there is hope that people are beginning to understand what we need to emphasize in life. And I really think the idea of healthcare becoming more and more of a right is something that people are beginning to realize. The United States is a system of systems. We don't have one healthcare system. We're like an awkward teenager. We don't know what we want to do. We don't want to be socialists, but Medicare, Social Security, Medicaid, these are not capitalist enterprises, right? So we have to make that decision sometime down the road. What do we want to do? Do we want to be like them, or do we want to continue doing this because this whatever we're doing right now isn't working? But I think more and more people are beginning to realize that, and that gives me hope for medicine. And then what was the last one you said?
And the mission ahead for your
Oh,
future.
well, the mission ahead for the future is to continue to learn, continue to become a better person, continue to become a better physician leader. And as far as what gives me hope for that, really, it's just at the end of the day, this journey that I've had in the last 15 years has been so fruitful and so rewarding. It's been difficult. It's been filled with lots of failures. There's no shame in admitting it, but knowing that I've been through all that is what gives me hope on a day-to-day basis. I hate saying this, but I've got this. I know that sounds a little bit cocky, but at the end of the day, when you go through all these things in life, you really understand the value of what you've earned, and you really will work harder to keep it and work harder to continue to grow. And so that is key for anyone, is when you've been through all that, look at what you've been through, look at what you can achieve. And that takes time, but you have to be willing to understand what you're worth. And that only comes through success and failures.
Exactly. Lovely conversation. Really
Yeah.
enjoyed it, Dr. Krishna. And thank you so much for your time. I love that the hope that you find is because you remember that you have made it through the hardships and struggles. And
Mhm.
so I hope all the listeners out there can really gather that this conversation dug deep into understanding resilience too.
That,
And that the hardships you face, you'll overcome it. As you said, you got it because you know what you've been through and you know what you've accomplished despite facing the hardships in life.
mhm.
And so, thank you again for your time. And I hope that everyone enjoyed this conversation and can really gain a lot of information from it. And I hope that you can spark hope wherever you are, in your communities, in your families, and have a wonderful week ahead. Thank you so much again.
Thank you so much for having me. I really appreciate it, and looking forward to hearing some amazing feedback from your audience, and whatever we can do to continue to inspire people. You and I, we're here to inspire others going through the journey that we've been through. So
exactly. Thank you so much. Thank you. Have a great week.
You too.
Thank you for joining us on this episode of Medicine Motherhood Missions. We hope you found inspiration, insight, and a sense of connection in the stories we shared today. If you've enjoyed today's episode, be sure to subscribe and leave us a review. Your feedback helps us reach more listeners like you. Follow us on Instagram for updates, free downloads, and to join a community of like-minded individuals passionate about making a difference through medicine, motherhood, and mission work. Remember, you're not alone in this journey. Until next time, keep sparking hope, keep healing, keep nurturing, and keep making a difference. This is Johanna signing off from Medicine Motherhood Missions. The medical opinions expressed on this podcast are for the informational purposes only and should not be considered as medical advice. Always consult a licensed healthcare provider for personal medical questions or concerns. The views expressed by guests are their own and do not necessarily reflect those of the podcast host.